It's a great pleasure to be here today to talk about the research. Emily, who will be coming up presently, and I are very pleased to do this. Now, this is, as the chairman mentioned, a follow-up of an earlier survey that was conducted in 1999 by my then PhD student, Jan Mitchell, and myself. That survey was a collaborative venture initiated by my mother, Peggy Bradley, who had a macular condition. And her experience of diagnosis was grim, and she wondered how others fared. So she set about designing a questionnaire to discover how other people with macular conditions experience their diagnostic consultation. And she at that time, she recruited one of her neighbours to do the typing of this questionnaire. But designing questionnaires is central to my own work as a health psychologist, and I design patient-reported outcome measures for people with long-term conditions that are used worldwide in pharmaceutical trials and in clinical practice. So when I found my mother designing a new questionnaire, it wasn't long before I rolled up my sleeves and set about helping. So, and soon after that, added macular conditions to my list of research interests. And my mother and I took the original draft survey to the trustees of the Macular Society to ask for their support in doing this survey with their members. And they were very forthcoming. They provided some initial funding and supported the distribution of questionnaires to a sample of the members. And Marion Davis, who was then the CEO, encouraged the membership to participate from this platform and inside view. And participate they did. We had a magnificent response rate of 71%, which is unheard of in unsolicited surveys coming through the post. At that time, the membership were not used to surveys. This was the first that they'd received, and they did respond magnificently. We had other collaborators in this research. Stephen Anderson, an optometrist and psychologist at Royal Holloway, participated with us in the design of the survey, and Tim Fitch, the ophthalmologist, was also a great resource throughout the work. That work was published in Sideview and subsequently in the British Journal of Ophthalmology in 2002. 14 years later, Helen Jackman, who was the CEO of the Macular Society until recently, wanted a follow-up. The first survey had been valuable for campaigning for improvements to services for people with macular conditions. But now ophthalmologists were saying that work was out of date. We've improved, they said. You can't quote those findings to us anymore. So Helen came to us and asked us to do another survey and find out just how much they had improved. And the Society funded another PhD student, Emily Boxell, was appointed to work with me on this latest survey. Jan Mitchell continues to advise, and following Tim Fitch's retirement, Nottingham ophthalmologist Winfried Amoaku provides essential specialist input. Emily and I were conscious that the members of the Macular Society have had a lot of surveys since our first survey, and they might not be quite so enthusiastic to fill in another one, especially as it was longer than the last one. So we sent the survey to a sample of 4,000 members, which was quite a ambitious number. And they did respond extraordinarily well. And we thank you all who participated for your patience and stamina in completing the long survey. And a special thanks to my mother and her Leicester group and the Maidenhead group who helped pilot the survey when it was in an even longer state. In November 2013, the latest survey was sent out, and the membership didn't let us down. Emily had 11 sacks of post delivered in one day in December last year, and her office looked like Santa's grotto. Indeed, we did have to recruit some volunteers from the psychology students to act as elves to help with the data input. But the results are fascinating, and comparing the responses with Jan's 1999 survey shows us what has changed and how. And we can see that there have been improvements in diagnostic consultations, but we can also see that more improvements are needed. I'll now hand over to Emily to give you the preliminary results to date. Thank you.
So it's a pleasure to be here today to give some of the initial results from the Macular Society 2013 survey. I'm really delighted to be taking part in this project, which is helping giving a voice to the members of the Macular Society. So we received a good response rate to the survey of 39%. So that means we received more than 1,500 paper copies back. And we also went over the survey over the phone with 26 respondents as well. The majority of people that completed the survey had age-related macular degeneration. 81 had other types of macular conditions. So a majority of respondents were women, and on average, people were diagnosed around 7 years ago. So the survey itself had a lot of questions about the different experiences of living with the macular condition. I actually have a couple of blank surveys with me today, so if anyone wants to look at the blank copies of the survey, please do and ask me after this talk. The survey itself had lots of questions on low vision support, experiences of diagnosis, experience of treatment, and possible perhaps delays to diagnosis as well. And we also included some questions that related back to the 1999 survey, which Clare was talking about before. And this survey found that many people had unsatisfactory experiences in their diagnostic consultations. So we replicated some of the key questions from the 1999 survey in the 2013 survey to enable direct comparison. Now, the Royal College of Ophthalmologists guidelines, produced in 2009, also has some recommendations for improving patient-centred care. And so we included some questions in the survey which related to this as well. So I'm just going to give a overview of the results that I'll be talking about today. So first of all, I'll be talking a bit about the doctor-patient relationship, satisfaction or dissatisfaction with the diagnostic consultation. I'll then be looking at experiences of whether people received the help, support, and advice that they needed at the time of the diagnostic consultation, and whether they received the information that they needed as well, and also why it's important they receive this information. I'll also be looking a little bit about experiences of hallucinations as well. So first off, one of the key questions from the 1999 survey was whether the respondent felt that the healthcare professional who diagnosed their macular condition was interested in them as a person. Now, we've seen some significant improvements in this, which is good. So in the 1999 survey, 46%, so that's fewer than half of respondents, said that the healthcare professional felt that they were diagnosed, felt that the healthcare professional who diagnosed their macular condition was interested in them as a person. And this has increased significantly. So in the 2013 sample group, this is now 71% of people. So about 7 out of 10 people said this. So this is an early indicator that things are improving. Next, we asked about satisfaction with the diagnostic consultation. And we're also seeing some significant improvements here as well. So in the 1999 survey, 59% of respondents said they were satisfied with their diagnostic consultation. And in a 2013 group, this has since increased to 75%. So 3/4 of all respondents felt they were satisfied with their diagnostic consultation. And we asked respondents if they could give the reasons for their response. I've yet to analyse these in great detail, so this is just the initial results that I'm presenting here. But it does appear that some of the reasons for dissatisfaction in the 1999 survey also similar in the 2013 sample. So for instance, in the 1999 survey sample, the top reason for dissatisfaction was the eye specialist attitude. So some people wrote that the eye specialist was abrupt, patronising or dismissive, and some people said that the consultant talked to their colleagues whilst ignoring the patient. And disappointingly, this does seem to be the case for a small minority of people. So I'm just going to read out one of the quotes from a 2013 survey respondent. He said, "I was first seen by a pleasant young doctor who began to explain the situation to me. Within a few moments, an eye specialist burst in, ignored me, spoke over my head, looked at my eyes and said, 'We can't do anything about the MD, but she could have a cataract op.' I had no idea I needed one. Bundled upstairs, I was alone and had received no support at all. I was shaking with apprehension and anger. His treatment of me was appalling, a complete lack of compassion. It was a dismal start to a new future." So this just shows that also that news that's delivered in an unsympathetic way can obviously be quite shocking to patients as well. And this can be related to increased depression and decreased morale in the future. Now, there are other reasons for dissatisfaction as well. So many respondents said that they didn't receive enough information about their macular condition or further contacts for help and support. Others say that they didn't have enough time in the consultation. And some people said that they had trouble getting appointments themselves, which had a knock-on impact on getting treatment. And some people said that they were told that nothing could be done to help with their macular condition. And said quite blankly, this is quite upsetting. And this is illustrated by another quote that I'll read out from a 2013 survey respondent. So they said, "The person I saw just said I had AMD and there is nothing we can do. I was devastated and no more explanation was given." So this just shows the emotional reaction to being told that nothing can be done as well. And this can be a bit misleading as well, because although many people with a macular condition may not be able to have medical treatment for their condition, they can still be offered low vision rehabilitation, which can help them make the most of their remaining vision, and also peer group support, which I know a lot of you benefit from. So the blanket term that nothing can be done should really be avoided. Now, of course, I've just been talking about some of the negative responses, but just 75% of people did say they were satisfied with the diagnostic consultation. So I'll read out some positive comments too. So one respondent wrote, "The specialist went into great detail about MD and gave advice regarding treatment and future outlook." So this just shows that some consultants are giving information that patients need. Someone else wrote, "It was more than satisfactory, first class, everything explained clearly and carefully." And others talk about the healthcare professionals seeming generally concerned for their well-being, and talking to them really helped their worries over their condition. So these are some good examples of best practice. So some of the common themes that have been running through those quotes are talking about whether patients feel they're getting the support and the advice that they need. We did have a question asked specifically about this as well. And we found that 55% of the 2013 group respondents felt that they were getting the appropriate support and advice that they needed. However, of course, this means that 45% of people aren't. So this is an area that does need to be improved. So next I'm going to be talking about some of the more specific aspects of the diagnostic consultation. And these are also recommendations that are included in the Royal College of Ophthalmologists guidelines. So first I'm going to be looking at provision information. And research generally shows that the more information one has about their condition, the less anxious and depressed they'll be, and the more adjusted they'll be to their condition. So first we asked respondents if they were given the name of their condition at the time of diagnosis. And we're seeing some significant improvements here as well, which is good. So in the 1999 survey, 76% of people said they were given the name of their condition at the time of diagnosis. And this has since gone up. So in the 2013 survey group, this is 88%. So nearly 9 out of 10 people said they were given the name of their condition. Of course, this still means that 1 out of 10 people aren't being given the name of their condition. Now, it's important that people are given the name of their condition at the time of diagnosis, because people are able to talk about their condition, they're able to get more information and research about it. And also, if one is given the name of their condition, they also know that the symptoms might not be due to something else, something perhaps more serious. So we then asked if patients were given written information at the time of diagnosis. Now, 69% of people said they weren't given any written information. Now, being given written information is important because many people, when they're first diagnosed with a macular condition, can understandably be quite shocked. And this is illustrated by one quote which I'll read out. So this is from a 2013 survey respondent. So they wrote, "The information was too blunt. In 10 seconds, I knew I had AMD, could lose my sight, and there was nothing I could do about it. Whatever else was said, this was all I heard." So in this instance, for this patient, and for many other patients like this, it's useful to be given written information that they can take away and look at this information in their own time when they're ready, perhaps with the help of a friend or a family member. Additionally, some people, when they're first diagnosed with a macular condition, they're seen in the hospital once and then discharged, so they may need this written information to refer back to later on. So the Royal College of Ophthalmologists guidelines do suggest that information should be given on the likely progress of the macular condition. However, we're actually seeing that people are getting less information on this than ever before. So, for instance, before the guidelines were published in 2009, 45% of people reported being given this information, whereas after the guidelines, this is 39%. So people are getting less information on this. Now, why might this be? It could be that with the introduction of anti-VEGF injections, it's actually quite difficult to give a likely prognosis for a condition, and therefore, because reaction to this treatment is rather individual. It also could be that because we're asking healthcare professionals to give more information and more support within their consultations, they have to deprioritize other aspects of the consultation, such as giving information on likely progress. However, we do recommend that at least some information is given on this, because many respondents to the survey reported that if they weren't given any information at all, then they thought they might be going completely blind, which is highly unlikely to be the case because of a macular condition. So this is illustrated by one quote. "The consultant told me I had early ARMD. I was upset and frightened. I have no vision impairment yet, and I asked how it would progress. She shrugged her shoulders and put her hand out to shake mine. End of consultation. No reassurance at all. I felt so alone and very tearful." Many people report wanting to get further information for help and support after the consultation. So we asked our respondents if they were given any of this. Now, as obviously the majority of you know, the Macular Society are the experts at giving information on macular conditions. However, only 24%, so that's 1 in 4 people, were told about the Macular Society at the time of diagnosis. Now, this is really quite low. And that is actually even lower for other contacts for help and support, such as the RNIB or local support groups. Only 18% of people were told about this at the time of diagnosis. Now, this is quite surprising because, as I've spoken a bit about before, consultants might not have enough time in a diagnostic consultation to give out all the information and support that's needed. So therefore, it's all the more important that these further contacts for help and support are given at the consultation. And at the very least, leaflets and posters could be put up in the eye clinics displaying this information. So the last part of the talk that I'm talking about today is about hallucinations. And I know Dominic Fitch will be talking about this in a bit more detail later on. So visual hallucinations can appear as people, faces, plants, trees, or animals, or patterns, and are known as Charles-Bonnet syndrome, or CBS, and they're a common side effect of sight loss. Now, the Royal College of Ophthalmologists guidelines do state that patients should be given information at the time of diagnosis. However, only 15% of people were alerted to the possibility of having a visual hallucination. So this is obviously really quite low. And it's quite surprising given the amount of possibility that the Macular Society and the RNIB have been giving about visual hallucinations. So this might be because, as we were talking about before, there might not be enough time to give out information about visual hallucinations within the consultation. But in this case, the Macular Society do provide written information in the form of booklets which could be given to patients. So we asked respondents if they had experienced any visual hallucinations themselves, and 364 people said that they had. So that's about 1/4 of respondents. And 35% of these people said that they'd seen a healthcare professional about them. So that suggests that 2/3 of people who are experiencing visual hallucinations aren't seeing a healthcare professional about them. Why might this be? It might be because some people might be quite reluctant to talk about them if they attribute the cause to a more serious mental health issue, such as dementia. And if my understanding, we might not be told about this condition. And it also might be that the Macular Society, as I said, are producing more publicity about it, so the members don't feel they need to see the healthcare professional about it, as they already know the cause. So when we asked our respondents if they'd received a cause for the hallucinations from the healthcare professional, and we've seen improvements here as well, which is good. So in the 1999 survey, fewer than half said they were given a cause for the visual hallucinations, whereas in the 2013 sample group, this had risen to 61%. And the causes given were also more accurate this time round. So in the 1999 survey, the causes given were due to age, due to stress, psychological reasons, or brain confusion, or actually nothing to do with the macular condition at all. Now, these causes were linked to, well, also not very accurate or reassuring, but they're linked to poorer well-being as well. So the causes given in the 2013 survey sample, people were told they were accurate responses, so it's the brain's response to reduced visual input, or they were told it's simply due to the macular condition or to visual loss, and 15% were told that it's due to Charles-Bonnet syndrome. So although they weren't given a label for the condition, they could take they weren't given the biological cause for the condition, they were given this label which they could take away and get research on if they wanted to. I'm also done some preliminary analysis on the impact of hallucinations, and this has found that people that experience visual hallucinations do tend to have poorer quality of life and poorer well-being. However, I do need to do some further analysis on this to take account of other factors, such as age and severity of macular condition. I'm also hoping to do some further analysis looking at the impact of different types of hallucinations. So, for instance, seeing patterns, seeing versus seeing people, are the different impacts on quality of life and well-being. So I've got a lot of work left to do on this data set, but we are seeing from the initial responses that there have been improvements in diagnostic consultation experiences. And in particular, people are getting more information and support than they were 15 years ago. Now, the reasons for this might be that the results of the survey were published in the British Journal of Ophthalmology. Ophthalmologists may have read this and adjusted their behaviour accordingly once they've realised the low patient satisfaction in the consultations. Alternatively, of course, the Macular Society have been involved in campaigning for better healthcare services and promoting the results of the 1999 survey. Of course, the Royal College of Ophthalmologists guidelines, produced in 2009, may have improved healthcare behaviour experience for the better. We've actually done some initial analysis looking at the effect of time, and we're seeing that after the guidelines were published in 2009, there do seem to have been some significant improvements in most of the areas that I've spoken about today, apart from in 3 key areas. So this is on giving information about hallucinations, the likely progress of a macular condition, and further contacts for help and support. So these are 3 particular areas that do need to be improved on. So all it leaves me to say is a massive thank you to everyone who completed the 1999 survey and the 2013 survey. Without your responses, we wouldn't have been able to see where these improvements have been made, but where also there is still some room for improvement. So thank you.